It's almost time, so we are going to start our webinar today. Good morning and good evening, all my friends in ICC. I'm Dr. P.Y. Cho from Chang. Today, myself and Dr. Tinchen Lu and Dr. Paul Chen Huang will co-moderate this webinar today. Today, we are so happy to invite our friend, Professor Hikosaka from Japan, to give us a very special lectures. Before Professor Hikosaka has been introduced by Professor Po Shen Huang, in the very beginning, I would like to introduce our panelists. We are so happy to have three very well-known cleft-related surgeons in the world to come join our panel discussion today. The first one is from Brazil, Dr. Daniela Tanikawa. Hello, Professor Tanikawa. Hi, from St. Paul. And our panelist is from Indonesia, the Rumah Sakit Kramat 128, Dr. Dwi Wicaksono. Hello, Dr. Dwi. Dr. Dwi just got married 2 days ago or yesterday. Congratulations. Happy weddings. And the third one is Professor Sarah Yu from the Thailand Mahidol University. However, he just told me he got a fever, so he cannot be here with us. So hope him can get a recovery speedy. Okay, so first of all, I will invite Professor Po Chen Huang from National Taiwan University to give an introduction for our Professor Hikosawa. Professor Huang, please.
Okay, I'm Dr. Huang. It is my honor to introduce today's speaker, Professor Makoto Hikosaka. Professor Hikosaka is graduated from the Keio University, and he finished his resident training and being the associate professor in the Keio University in 2006. Then he worked other famous medical center and to being the chief of the Department of Plastic Surgery, Hiratsuka City Hospital. Then he was being the chief in the Division of Plastic Surgery and the National Center of Child Health and Development in 2021. He also is a member of the Japan Society of Plastic and Reconstructive Surgery and many consultant for the cleft palate organization and simulation surgery, and one delegate of the Japan Society of the Craniomaxillofacial Surgery. Today, Professor Hikosaka will present a special topic about CLEFT-Q, Cleft-Specific Patient Report Outcome, Experience in the National Children's Hospital in Japan. Let's welcome Professor Hikosaka.
Thank you for the introduction. Hello, everyone. Do you see my slides on the screen?
Not yet, Professor. Okay. You have to share again.
How is it now?
Yes.
Good.
Yes.
Okay. Great. Okay. So hello, everyone. Today, I am going to talk about CLEFT-Q, a cleft-specific patient-reported outcomes. Part of the study is funded by public and institutional research funds, but there is no conflict of interest to declare. Our center, National Center for Child Health and Development, is located in Tokyo, Japan. This is a map of Tokyo. Asakusa, Skytree, Tokyo Tower, and all the main spots are on the eastern side. Our institution is located on the western side. This is our neighborhood. We have movie studios nearby, and famous movies like Godzilla, Ultraman, and Seven Samurais were born here. This is our institution. We are surrounded by trees and ponds, and in daytime, we see kids playing in the garden. In winter, we make Christmas tree with origamis gathered from all the kids in the hospital and our neighbors. I am a plastic surgeon, and we operate on conditions such as craniosynostosis, cleft lip and palate, microtia, lymphatic malformation, syndactyly, and myelomengingocele. Today, I am going to talk about cleft care at our center. Primary goal of cleft lip repair is to achieve symmetric appearance of the nose and lip while minimizing the scar. Our protocol for surgery is between 3 to 5 months of age. For unilateral cleft, we operate by rotation advancement technique combined with a small triangular flap, because we believe this is the most effective method to move the tissues to a symmetric position. Rotation incision effectively elongates a white lip, and a small triangular flap further elongates a white lip. We are not so happy with the horizontal incision at the alar base, but without this incision, medial advancement of the alar base becomes too large because the lip has to advance close to the midline to fill the defect at the rotation incision. With the horizontal incision at the alar base, the nose component and lip component are separated, and the amount of advancement of nose and lip are differentiated. We are currently trying to refine our method to avoid the horizontal scar. The primary goal in cleft palate repair is to restore filopharyngeal function while minimizing scarring, which interferes with maxillary growth. We typically perform this surgery around 1 year of age. The modified Paulo technique enables firm reconstruction of the levator belly palatine muscle, lengthening of the soft palate, and leaves no mucosal defect in the anterior palate. In modified Paulo palatoplasty, the Z-plasty is made smaller. This facilitates easy transfer of Z-flaps. Lateral relaxing incisions facilitate muscle dissection from posterior edge of the hard palate and the hamulus. They also facilitate easy transfer of Z-flaps. With these modifications, double opposing Z-plasty becomes applicable to all cleft types. Lateral incisions may interfere with maxillary growth, and we are not very happy about them, but I am not yet sure if we can dissect and mobilize the muscles without them. We will continue to refine our methods for better outcomes. The primary goal in operating cleft alveolus is to provide adequate bone support for the eruption and alignment of teeth. We perform the operation according to the conditions of the teeth. If the central incisor is rotated due to deficiency in alveolar bone, surgery is performed before its eruption, so that central incisor may erupt in a straight orientation. If lateral incisor is present, we operate before its eruption. If lateral incisor is absent, we operate before the eruption of canine tooth. This was a brief overview of our protocol. Now I would like to talk about CLEFT-Q, questionnaires for cleft patients. Cleft lip and palate can present a variety of symptoms such as aesthetics, speech, occlusion, and psychosocial aspects. This table shows the conventional outcome index and the validated methods for assessing various aspects of cleft-related symptoms. These are all based on clinicians' perspectives, and there are no evaluations from patients' point of view. Moreover, these are limited to aesthetics and functions, and there is no psychosocial index. In addition, psychosocial aspects can be evaluated only by the patients themselves. This slide summarizes the issues with the conventional outcome index. Number 1, there is a lack of patient's point of view. Novel outcome measures from patient's point of view are awaited. Number 2, there is a lack of psychosocial evaluation. Inclusion of psychosocial aspects will enable more holistic care. Number 3, some of the conventional outcome index lack sufficient reliability. For example, the inter-rater reliability of Asher-Magdade method, which is used to evaluate aesthetics, is 0.66, which is acceptable but not excellent. Patient-reported outcomes, or PRO, are defined as all the outcomes reported by the patients themselves about their health. Patient-reported outcomes include symptom scale, satisfaction scale, and health-related quality of life, or QOL. For example, regarding pain, symptom scale asks patients, how bad is your pain, describing you 0 to 10. QOL asks, do you have difficulty with your work because of pain? And satisfaction scale asks, how much are you satisfied with the control of your pain? Why are the patient-reported outcomes important? Because outcomes evaluated from patients' perspectives are not equal to the outcomes evaluated from clinicians' perspectives. We need to focus more on the outcomes that are valued by the patients. But are you not thinking? QOL, PRO, are they scientific and reliable? In the past, subjective evaluations were vague and not measurable. Today, psychometry, which is a science that measures minds, enabled scientific measurement of subjective evaluations. Patient-reported outcomes are valid and reliable. It can be scored by questionnaires that have been validated. It is scientific. The scores can be used as scientific evidence. Patient-reported outcomes are used in clinical research, clinical trials, and insurance reimbursement in many countries. In the US and in Europe, there is a guideline for using QOL for approval of drugs and medical devices. For the score of the questionnaire to be used as scientific evidence, their reliability and validity must be evaluated. For example, content validity means is a questionnaire asking the questions that matter to the patients. And construct validity means is a questionnaire measuring what you really want to know. CLEFT-Q is a patient-reported outcome questionnaire for cleft lip and palate. It covers the entire aspects of cleft-related symptoms. It consists of 13 scales. Each scale is expressed as a 100-point interval scale, which means that the significance between each point is equally spaced. It can be applied to patients equal to or older than 8 years old. It is free to use for clinical and academic purposes. The questions cannot be shown here because it is copyright protected, but I will share with you some of the questions that are open to the public in a website. This is an example of a question about aesthetics. How does your face look? How much do you like how your face looks when you look your best? The patient is asked to respond from the 4 choices from not at all to very much. This is an example of question about speech. How do you feel about speaking? My speech makes it hard for me to make new friends. The patient is asked to respond from the 4 choices from never to always. This is a question about occlusion. How do your teeth look? How much do you like how your top and bottom teeth meet when you bite? And this is a question asking about psychosocial status. How is your school life? I like seeing my friends at school. Each scale of CLEFT-Q consists of multiple questions like this. For example, the SCAR scale asks 7 questions about how the scar looks to the patients, and the face scale asks 9 questions about how the patients feel about the appearance of their face. CLEFT-Q is validated. It was developed based on patients' and experts' opinions, and its content validity is established. CLEFT-Q is reliable. In a study with more than 2,000 patients from 12 countries, the relationships between CLEFT-Q scores and the severity of the symptoms were confirmed, and average scores were established. CLEFT-Q is widely used. It has been translated into more than 20 languages. Standard set of outcomes is a recommendation of a set of data to be collected prospectively for care improvement, meta-analysis, and international collaborative research. Standard set of outcomes for cleft lip and palate was proposed in 2017 through ICHOM in a 7-country collaboration. This statement recommends collect objective and subjective evaluations in addition to objective evaluations, and use CLEFT-Q for subjective evaluations of aesthetics, speech, eating and drinking, and psychosocial status. Japanese version of CLEFT-Q has been developed through collaboration of 6 institutions. Translation was completed in 2020. It was confirmed that the language was appropriate for Japanese patients. CLEFT-Q was made ready for evaluation of individual patients. Evaluation of construct validity was completed in 2023. It was confirmed that the scores of CLEFT-Q reflect patient status. CLEFT-Q was made ready for cross-sectional study. Evaluation of responsiveness is underway. We have collected CLEFT-Q scores from 30 patients before and after treatment. The question, does CLEFT-Q reflect changes in patient status, is being tested. When this is done, CLEFT-Q is ready for use in prospective studies. Here, I would like to talk about the details of our validation study. The aim of the present study was to evaluate construct validity of Japanese version of CLEFT-Q. This was a cross-sectional observational study done in 6 centers in Japan. Target number of patients was 100. This number was based on the subject-to-item ratio of 5, which means that at least 5 patients per question is required for validation study. Inclusion criteria were 8 to 17 years old, unilateral or bilateral, cleft lip, alveolus, and palate patients. We chose this type of cleft because patients with cleft lip, alveolus, and palate experience all aspects of cleft-related symptoms. Main exclusion criteria were syndrome, other craniofacial congenital anomaly, and those attending special needs classes. This table shows the outcomes collected in the study. For each aspect of cleft-related symptoms, CLEFT-Q and subjective evaluations were collected. For subjective evaluation, we asked patients if they desired improvement or additional surgery for each of their cleft-related symptoms, namely aesthetics, speech, occlusion, and eating and drinking. For psychosocial aspects, we asked the patients if they attended and enjoyed school. Objective evaluations were collected at the same time. For aesthetics, surgeons reported if the patient required revision surgery. For speech, speech therapists evaluated the patient's velopharyngeal function. Occlusion was evaluated based on presence or absence of anterior crossbite. For eating and drinking, patients were asked if food or fluid comes out of their nose. No objective evaluation was done for psychosocial aspects. To evaluate construct validity, scores of CLEFT-Q were compared based on patients' subjective evaluation. CLEFT-Q scores of the patients with desire for improvement were compared with the CLEFT-Q scores of the patients without the desire, with unpaired t-test. For psychosocial scales, the scores were compared between those enjoying school and those who are not. The same comparison was made based on objective evaluations as well. CLEFT-Q scores of the patients with favorable outcomes were compared with the CLEFT-Q scores of the patients with less favorable outcomes, with unpaired t-test. Results. The response rate was 79%. We had valid responses from 111 patients. There were 72 male and 39 female patients. Mean age was 11 years old. This slide shows the results based on subjective evaluations. The upper graph shows the CLEFT-Q scores of the patients with and without the desire for improvement. And the lower graph shows the CLEFT-Q scores of the patients with and without desire for additional surgery. For psychosocial scales, CLEFT-Q scores of the patients who enjoy and do not enjoy school were compared. Please note that the patients with desire for improvement or additional surgery score significantly lower in the relevant CLEFT-Q scales. For psychosocial scales, patients who answered that school is fun scored significantly higher. This slide shows the results based on objective evaluations. The graph shows the CLEFT-Q scores of the patients with favorable outcomes, showing in blue bar, and less favorable outcomes, shown in red. Please note that the patients with favorable outcomes, shown in blue bar, scored higher. This slide summarizes the findings. Japanese version of CLEFT-Q was validated in 12 of the 13 scales based on the patient's subjective and clinician's objective evaluations. CLEFT-Q reflects the patient's and clinician's evaluations. The correlations with CLEFT-Q and clinician's evaluations were low, except for aesthetic scales. Patients' perspectives are not always equal to the clinician's perspectives. CLEFT-Q can elucidate the patient's perspectives that are difficult to know with conventional objective evaluations. CLEFT-Q is an indispensable tool in cleft care. I would like to share with you our experience with this 7-year-old female patient with cleft lip, alveolus, and palate. There were no complaints heard from the patient at the outpatient clinic. At a regular follow-up visit, the patient filled in the CLEFT-Q. On the way home, she complained to her mother, "I'm worried about the deformity of my nose." On physical examination, we observed hooding of the left nasal tip and nostril. This is her CLEFT-Q scores. Nose and nostril scores were especially low, supporting her complaints. Based on her desire, we planned a nose revision. Reverse urinoplasty was performed, and hooding of the nostrils and nasal tip improved. This is her CLEFT-Q scores before and after the nose revision. Nose and nostril scores improved. We could confirm that the surgery was effective from the patient's perspectives as well. Social score also improved. This might have been a secondary effect of surgery, improving her self-esteem and making her feel more confident in social interaction. But the face and jaws score remained low. This may be due to facial contour due to maxillary hypoplasia. She is planned for orthodontic and jaw surgery. This slide summarizes the significance of CLEFT-Q in this patient. CLEFT-Q can draw out the patient's desires and complaints and objectively view them as scores. It may be difficult for children to express their complaints and desires to clinicians, but with the help of CLEFT-Q, they can express their concerns. The results are expressed with scores and easy to understand for the families and the clinicians. CLEFT-Q can aid in determining the treatment plan based on patients' perspectives. And after the treatment, we can evaluate the results from the patient's point of view. We are currently working to elucidate further psychometric properties of CLEFT-Q, such as average scores of Japanese patients and cleft type and age-specific scores. We are also undertaking the implementation study. We hand QR code to the patients. Patients respond to CLEFT-Q online. Automatic scoring and visual presentation is provided to the clinicians. This system will enable us to use CLEFT-Q in everyday practice. Incorporation of CLEFT-Q into cleft care will enable understanding the patient's point of view. Incorporation of patient-reported outcomes is in the practice. It will enable incorporation of psychosocial outcomes, making more holistic care possible. And it will enable integration of patient's voice in decision-making, implementing shared decision-making. All this will improve the quality of cleft care, enabling patient-centered care. We are hosting an international congress on cleft lip and palate and the related craniofacial anomalies in Kyoto this October. Our theme is harmony. Harmony is a part of old name of our country and the heart of Japanese culture. We wish to orchestrate in harmony with the visitors from all over the world. Kyoto is an old capital of Japan with rich history. It is also my hometown. This is my home. It's over 140 years old. Kurama Temple is located in the northern mountains. If you like green and mountains, this is a great place to visit. Yoshitsune, a tragic hero, spent his young days in Kurama Temple. He was a princess of Genji clan, one of two families of samurais. When Genji clan was defeated, he was only a baby and was confined to this Kurama Temple, not knowing who he was. Later, he led Genji clan to revenge on Heike clan, but he was killed by his older brother after the victory. Fushimi Inari Shrine is located in the south. You can walk through the tunnel with brick gates all over the mountain. Sagano is located in the western part. The bamboo tree walk is a great place. So make sure you come and join us in Kyoto this autumn. Thank you for your attention.
Thank you very much, Professor Hikosaka's comprehensive presentation about the CLEFT-Q. Besides, Professor Hikosaka is the program committee chairman for this Kyoto CLEFT this year in October. So that's why he encouraged all of our audience can meet in person in Kyoto. And Chang team and all the Taiwan's member will build up a kind of a huge team to attend this wonderful congress in October, and I hope to meet you in person as well. Okay, so I would like to invite our panelists to give some comment and some question for Professor Hikosaka. The first one, I will invite Dr. Daniela from the St. Paul. Yes, please, my friend Daniela, please give Professor Hikosaka some comment, please. Thank you.
This is a very important topic, and I'm really impressed about the correlation you did between the patient-reported outcomes with the clinicians' reported outcomes, because for sure we have different perspectives. And I think it was really interesting that you have included 6 centers. and you noticed there was differences. My question is, did you notice difference between centers? Was it homogeneous discrepancies between the patient's reported outcomes with the clinician's reported outcomes? Because I think this can be a very important tool to evaluate individual treatment planning, but also programs evaluations, program protocols. And so this is my first question for you.
Thank you very much for the question. Actually, there were not many differences between centers, but I agree with you that this can be used to compare the protocols, which protocol is better for the patients. But currently, we see not many difference among the centers. This may be due to not many discrepancies, variations in the between the protocols taken in each center.
Okay. But also this is important too for auditions to evaluate your own protocol, right? For the centers to evaluate. Is there a thing that we can improve? So I know this is like a research, right? But do you plan to use it routinely at specific age, like 8 or in adolescents? Because they may have different point of views, the young children and the older ones.
Thank you. Yes, the CLEFT-Q is designed to use in everyday practice rather than for research use. And it is recommended that we collect CLEFT-Q at age of 8 years old. And then I forgot the exact age, but 2 more time points before the adolescence. So it is intended to use in routine practice. And we are now undertaking an implementation study with 7 centers this time. And we asked all the patients who visit the center, each institution, to fill in CLEFT-Q. And when they come into the room, we have the scores on hand, and we can talk with the patients based on that and the score. We're trying to, we've already built up ePro. That means the questionnaire working on online. We've already built up the system. So soon we're starting that. And hopefully we'll collect many responses from the patients and many responses from the doctors as well, like how the incorporation of CLEFT-Q changed their practice, the way they practice. So we're planning to use it in a routine practice.
Oh, this is very nice. And how long do you now you're thinking to implement for every patient in your workflow?
Right. But this entire CLEFT-Q consists of 119 questions. That's huge. And it takes about, like 8-year-old kid, it takes only like 5 or 10 minutes to fill in all the questionnaire because they don't think. They just circle the way they feel. But for adolescent kids, patients, it takes about 1 hour to fill in the entire questionnaire because some of the questions are so important to them. But we are asking patients to fill in the entire questionnaire at this moment because we want to collect the scores so that we will know the average scores of Japanese patients. But when we are done with the average scores, we will ask the patients to fill in the scales, a part of questionnaire that matters to the patients at that point of time. Like if you are planning nose revision for a patient, you can ask the patient to fill in only the nose, nostril, and face scale, and the rest of the skills, the patients don't have to answer. That way you can lessen the burden of the patients. So that's how the CLEFT-Q can be used.
Okay, and do you plan, so I believe you plan to use it also longitudinally to follow the same patient. So if this perspective, when he's a child, is different from he becomes adolescent, especially I think when you start having maxillary discrepancies, maybe, or is it more or less severe? Congratulations.
Thank you.
Okay, thank you, Daniela, for comments. And then the next panelist, I would like to invite Dwi Wicaksono from Indonesia. Yes, Dr. Dwi, please.
Thank you, Dr. Cho, and thank you, Professor Hikosaka, for the nice presentation. Actually, in my center, my senior has already developed also the CLEFT-Q and Indonesian version. But when we are trying to make a research for that, we have some difficulties like how to translate and also the cultural adaptation of the CLEFT-Q. So I would like to ask you about how do you and the teams from Sixth Center can deal with this problem about the translation and also for the cultural adaptation for the CLEFT-Q scale. Thank you.
Thank you. About the translation, it was done in my center, and so I was the main person who translated the CLEFT-Q, and the validation study that involved over 100 patients that was performed in 6 centers. Now, regarding translation and cultural adaptation, we also experienced many difficulties in translation. And one of the issues was that there was a question in psychosocial scale asking like, do you feel like I am proud of myself? And the patient is asked to answer yes or no, but Japanese 8-year-old kid won't say like I am proud of myself. It may be it may stand in like European or US countries, but not in Japan. So I went to the speech therapist and asked them like how the kids would express this kind of feelings. The speech therapist said, the kids often say that they are doing their best. They think they're doing their best. So I asked the original author of CLEFT-Q that Japanese patients won't be able to answer this kind of question saying like, I am proud of myself. But instead, we can write like, I feel I'm doing my best and I am happy with that. We can add those words under the I am proud of myself. That way, Japanese kids will be able to answer the question. And we had a long discussion with the original authors. And finally, in Japanese version, we added those words. So I think patients feel quite comfortable about answering the question. Now, that was about translation. And in using CLEFT-Q, we also faced many problems. And many the questions about aesthetics in CLEFT-Q asks patients how they like their appearance. But Japanese patients won't say like they like their appearance or not. It is regarded as a virtue in Japanese culture that they hide their feelings and they don't say it openly. So when I asked my patients, like, do you feel any difficulties in filling this questionnaire? Many of them answered that I have never thought about if I like my appearance or not. So I asked them, then how do you feel about about your appearance? And then they said, nothing. I feel just normal about my appearance. So I went to the original authors and said that like asking like or dislike in Japanese culture is not appropriate. And we had long discussion about that as well. But the original authors said that we can't change the wording of like or dislike because that's the fundamental part of the questionnaire. So this dislike or like issue is left in our CLEFT-Q. But many patients can answer that questions after all. So I think it's not comfortable, but it's acceptable. Those are the issues that I felt about the cultural adaptation.
Thank you very much, Professor.
Yeah, thank you, Dui. And then I maybe Bolton, do you have any questions or comment for Professor Hikosaka? Yes, please.
Thank you, Professor Hikosaka, to share your experience. Yeah. So I have questions about do you want to share the final report from the doctor's view and to share to the family about the relationship between the family's respect and the doctor's request. You have to discuss to share the different view from this kind of the questionnaire. Thank you.
Thank you for the question. Is a question about like managing the different point of view between family, patient, and clinician? Is that the core of your question?
Yeah, like this.
Oh, thank you. Okay. I don't know if this stands in your country, but often what we experience in Japan is that a family is so eager for like revision surgery, but kids are not, and doctor is in between. Do you have such experience in your country?
Professor Huang, you are muted. You are muted.
Oh, sorry. I think the patient, when he was grown up, maybe they don't want to do the more surgery. The family want to do more surgery. Maybe in these recent years, maybe doctors don't to give any suggestion, maybe to listen to the final result from the patient and his family discussed. The doctor didn't to do any more forcefully suggestion. Maybe I think this is the situation in Taiwan.
I see. Thank you. Well, we experience such situations very often. And I had an experience with 19-year-old girl with pharyngeal insufficiency. Her speech was like escaping out of nose. So we recommended her to have pharyngeal surgery to make her speech better. But she said that she didn't care about that, and she wanted her nose to be fixed. So and the family was like kind of confused. So I asked her to fill in CLEFT-Q, and that showed that she had no concerns about her appearance. She had no concerns about speech, but the scores for appearance was quite low. So after seeing that, we discussed with the family and patient, and the family was quite convinced with the CLEFT-Q scores because that was so in line with what she was saying. So after the discussion, we had her nose fixed and left the speech as it is. So CLEFT-Q can be used to confirm like what the patients are saying, and the scores. It comes in scores, and families can be convinced with scores. So I think it's useful in discussing about the treatment plan.
Well, thank you.
Okay, thank you, Professor Huang. And the last one, I would like to invite Professor Tatsu Oh from the Assam Medical Center to share his comment and experience. Yeah, Professor Oh, please.
Hi. Congratulations. First of all, congratulations on your great work. Actually, in Korea we have only Cleft-Q, so we try to make a Cleft-Q, but there is some problem that actually when we translate the Cleft-Q from English to Korean, they need some validation about Korean language, because after transferring, there is a problem that the language is not completely matched, that there is something bias, the language difference. So I really want to ask how do you overcome that kind of bias? And the second thing is that Cleft-Q is I think that it is a little bit long to ask. So it takes too much time. So for me, so the compliance problems that many parents cannot, I think that cannot finish that questionnaire. So how can you overcome that problem? And I really want to ask you that after finishing these great works and the feedback, is there any change about your practice after this work, before and after? Thank you. See you in Kyoto.
Yes, please. Please bring your entire team. Thank you for the question. About the difficulty in translation, pretty much similar to what I have said to the Wijaksono, that I think it is important to collaborate with your team, because like dentists or speech therapists or otorhinolaryngologists and plastic surgeons, oral surgeons, they all have different perspectives and different words that are given from the patients. So so I recommend your entire team to look at the Cleft-Q and find the wordings that are used in your country, so that the wordings will be natural to your patients. So I recommend that. And about the issue that the Cleft-Q is quite long, I agree with that. But after I am done with all these validation and psychometric property studies, I will ask my patients to fill in only the part of the scales that are important to the patients, so that the number of questions will be like 10 or 20. So selecting the scales will solve that issue. Also, the patients are quite happy in filling out the Cleft-Q, because I think they feel that doctors are trying to listen to them. So many of the patients don't actually complain about filling out the questionnaire. I think they're quite happy. I hear that they're quite happy about filling out the questionnaire. Also, there's a technology called computer adaptive testing. It's called CAT, C-A-T, computer adaptive testing. This technology reduces the number of questions while maintaining the reliability of questionnaire. you have to build up algorithm based on the responses from the patients. I am trying to collect responses from 300 patients that will enable building up the CAT CAT. After building up the CAT, we can reduce about 30 to 60% of the questions and still gain the same kind of scores. The English version has already been built, and there is an article about this CAT technology. The last question was about how this CLEFT-Q changed my practice. And well, first of all, I became more like I listen to patients more now, and also there are two patterns in the changing the practice, the way we practice. The first one is like this 7-year-old girl I presented. We were not planning nose surgery for her, but the response from the CLEFT-Q scores of given from her made us feel that we have to have the nose revision for her. So that was a change in practice. The another example is the 19-year-old girl I talked about. In that situation, we didn't change the plan. We didn't have the velopharyngeal surgery based on her opinions. So both ways, we can change the plan. It can change the plan, or it may not change the plans if the patients are happy and don't want any more like further surgery. So that both ways it can turn out, and CLEFT-Q is useful in making decisions. Thank you.
Thank you.
Okay, thank you, Professor O. And then we have several questions from the audience. And the first one is from Dr. Genga. His question is, what age do you consider to be the best for application of CLEFT-Q? Yes, Professor.
Thank you. The CLEFT-Q can be applied to the patients equal to or older than 8 years old, 8. And the upper limit, there's no upper limit. As I have said, if you ask 8-year-old, especially boy, well, girls are more like considerable, but if you ask 8-year-old boys, they just don't think and they just feel in as they feel. But I think that's okay, because if the questions don't matter to them, then they have no worries about them. So I think there is not like particular appropriate age to apply CLEFT-Q, but you have to make sure that patients can understand the questionnaire, and that also patients themselves fill in the questionnaire, like families are not like interfering with the answering. And also, sorry, please wait.
Yeah, no problem. So we have the next questions. The next questions is from Dr. Dean. His question is that what should the treatment, the decisions should be if there is the differences between the patient and the doctor's perspective is different. Yeah. For example, 8 years old, the patient requests for the rhinoplasty, but the clinical perspective recommend waiting. So what is your comment for this?
I think it's an issue between like paternalism, meaning doctors make the decisions for the benefits of the patient, and like and autonomy, meaning patients make their own decisions, and you have to take the balance between them. We are clinicians, and we're also adults. We can like we can see the future of the patients, so we can foresee like what's best for their future. So there is a place for paternalism in decision making to some extent in cleft care. That's my idea. So if let's say if it's not an appropriate age for nose surgery, and it may interfere the nasal growth afterwards, then we'll ask the patients that that he has to wait. But um, but still, answering CLEFT-Q is useful. You can understand how he is feeling, and you can show your compassion to the patient. I see your score, and I see that you're concerned about your nose, but I'm also concerned with the growth of your nose. And I think it's best for now to wait for nose surgery. But I promised you that when your growth is complete, we'll do our best to make your nose straight. We can tell the patients, and that way we can make the use of CLEFT-Q. So that's my answer.
Thank you. Thank you, Professor Hikosaka. And then our next question is from Professor Handa. His question is, do you share the score of the CLEFT-Q with patient and the family during your consultation? Yes.
I am not sure at this point, but we're starting implementation study. In that study, we will have the score on the screen when we are consulting the patients. So I think we have to show the scores in most of the cases. So we have to prepare the how we're going to explain the scores to the patients. The problem is we don't know the average scores of the Japanese patients at this point of time. So let's say the score of 50, we are not sure if it's high or low. We have average scores from foreign patients based on over 2,000 patients, but we don't have Japanese average scores. So we have to be very careful about that. I'm still thinking about that.
Yeah, sure. Yeah, the last question is from Dr. Magna. Her question is, can CLEFT-Q could be used by recording the caregiver's reported outcome for those patients aged below 8 years old? Yeah.
Sorry, would you repeat the question? Can it be used in the recording?
Yeah, maybe the patient is below 8 years old, but could you do the CLEFT-Q for their parents or their caregivers? The
I
reported
see.
outcome,
Oh,
yes.
thank you very much. These questions are designed to be answered by the patients themselves. And when the family is answering the question, usually another version called the proxy version has to be developed, because that will be like, and that has to be validated again in a different manner. And I heard that the original author of original version, Dr. Karen Won, is trying to develop a proxy version, because she feels that we need to know how the patients younger than 8 years old feel, but there's no more information about that. So to the answer to that question, it has to be we have to wait for proxy version for that.
Okay, thank you, professors. I myself have one a little bit funny question for you, is that what is your reward for the patient to receive your questionnaire under the age below 10? And what is your reward for maybe the age a little bit like adolescent? Is it the difference is the toy and the lollipop and or some difference to give them for feedback? It's really could need a long time to collect a result for like our panelists comment the same. yeah, it's a little bit quite burden or kind of a very busy task for them to complete a whole entire questionnaire. Yeah, so it's a very difficult, it's a very challenging task for the might be the assistant. Yeah. So what is your reward? Just for
So your question is about like what is my reward for all this research?
yeah, sure.
Oh, okay, thank you.
Yes.
My dream is to implement Cleft-Q in everyday practice in Japanese setting, so that all the clinicians can understand how the patients are feeling. Like, I think we all have the issue that we can meet with our patients only like 2 or 3 minutes in the consultation room, and that's it. And that's not enough to understand how they're feeling. And when I met with this 7-year-old girl that I presented in a presentation, I was like so shocked that I couldn't understand like how she was feeling. And I want to avoid that kind of situation for all the CLEFT patients in Japan. So my dream is that I want to complete this work and I want to implement this CLEFT-Q, and so that all the clinicians in Japan can use this with so little burden that it's so easy to use, then it can be used in everyday practice. That's my dream, and that's my reward.
Yes, very good. Perfect. Congratulations, Professor Hikosaka. Yes, before our group photo, Dr. Tin Chen will give us an introduction for our audience in ICC, because in this October's the Kyoto CLEFT Taiwan team, our team leader, Professor Tin Chen Lu, will lead our team to bid the conferences, the 2033 that could be happen in Taiwan again. So Tin Chen, I will show the slide for you.
So we are excited to announce that we are preparing a to host CLEFT 2013. 这样有点怪。The proposed location is Taipei City, and the TaiNext Exhibition Center. The TaiNext features 19 conference rooms, and each capable of accommodating up to 3,000 people. And it is very convenient, located just 20 minutes from Taipei main station. So Taipei offers a wide range of hotels, and the brand new hotel is just 5 minutes walk from the venue. And Taiwan is a very safe country with a low crime rate. Additionally, a new shopping mall has recently opened near the venue. So Taipei City is full of attractions, and visitors can explore landmarks such as Taipei 101, the National Palace Museum, the Pingsea Sky Lantern Festival, and Jiufen Old Street. And during that season, you can also enjoy the hot springs at Yangmingshan and Beitou. And Taiwan is also famous for its delicious cuisines, so be sure to try Din Tai Fung's world-renowned xiaolongbao. If you love the ocean, you can also go surfing. There are several great surfing spots less than 1 hour from Taipei. So be sure to vote for us at the Kyoto meeting this year. Thank you very much.
Yeah, thank you, Tin Chen, for your wonderful introduction about Taiwan. Taiwan is a very beautiful island, and hope you guys can support our bidding in the Kyoto Club in October, and hope to meet you in person over there. So the final is our group photo times, and I would like to invite all our audience of ICC. We can open your screen to start your screen and to show me your smile, and then we can have a beautiful group photo. For the Kyoto meeting so far, till maybe we still have 6 months to go. And I believe that all the committee and all the members in the Kyoto, the club is very, very make their best to give us a very wonderful treat in Japan. So hope we can see you in person. And finally, Professor Hikosaka, do you want to say something for the Congress? Yes, please.
Make sure you come and let's see you in Kyoto.
Thank you very much. Very briefly and very heartfeltly. And I will count to 3 and giving a big smile. I will capture for all of us. 1, 2, cheers, smile. Thank you so much, and thank you, Professor Hikosaka, and thank you all my lovely panelists from Brazil, St. Paul, Daniela, and from Assam Medical Center, Professor Tatsuo, and Dewey from Indonesia, and thank you, Tinchen and Bolton. Thank you, Professor Handa. Our next ICC's webinar is 7 days later. Dr. Berner will give us a very specific and special topic that is talking about the rare facial cleft. You cannot imagine still has a lot of cases of rare facial cleft, and they were born in Philippines. And actually, we still need to learn their experience to treat those patients who in need, because it's very hard to see those kind of patients in Taiwan, even in the low birth rate country. So it's really a very interesting topic, and hope you can join with us in the coming weeks. Thank you very much. Good morning and good evening. See you next time. Bye-bye. Have a good day. Thank you, Professor Hikosaka. Thank you, Handa. Thank you, Daniela. See you in Kyoto.
Thank you.
Bye-bye, bye-bye. Thank you, Professor Fayaz. Bye-bye. 谢谢波成哦，感谢。今天 Juni 也没有空过来，大家比较忙一点。好，谢谢学姐。好，休息。
哎。